Today's webinar, Strengthen Your Poverty Reduction Work, Engaging with the Health Sector. My name is Alison Homer with Vibrant Communities Canada, and I'm here today with Dr. Gary Bloch and our host, Trish Garner. I'd like to start today's call by introducing our speakers. Trish Garner is the provincial organizer for the BC Poverty Reduction Coalition. She is a tea-swilling Brit with a passion for social justice. As the community organizer for the BC Poverty Reduction Coalition, a broad-based network of over 400 organizations throughout BC, she focuses on communications, outreach, and community engagement to raise awareness about the root causes of poverty and inequality and how we can collectively tackle them. She has a PhD in gender, sexuality, and women's studies from SFU and continues to work on LGBTQ issues. Trish lives with her partner and their 3 young children in East Vancouver. Dr. Gary Bloch is a family physician with St. Michael's Hospital in Toronto and an associate professor in the Faculty of Medicine at the University of Toronto. His clinical, research, education, and advocacy interests focus on the role of health providers in addressing the social determinants of health. He's a founding member of Inner City Health Associates, a group of physicians working in homeless service settings in Toronto, as well as the advocacy group Health Providers Against Poverty. He speaks frequently to medical and non-medical audiences across Canada and internationally on his experiences in working to transform the culture of healthcare to incorporate action and social changes to health. Welcome, Trish and Carrie, and thank you so much for joining us on today's broadcast. Trish, I'd like to hand it over to you now to lead us through today's discussion.
Great. Thanks, Alison. Hi, Gary.
Hi there.
Good to see you again. You know, the first time I met Gary was when we flew him in to do a speaker series with us here in BC. And I knew that he was a good guy when I picked him up early one morning and we drove up to Whistler and he took media calls on the way and we presented to local governments up there, and then we drove back and we stopped in North Vancouver and we did a webinar, and then we did an evening presentation, and he just rolled with it all. So I knew he was a good guy from then on. So I'm glad to be back, not in person, but at least to see you again, Gary.
It is great.
So to start with, our first question to get us going is basically a why are we both here having this conversation? So why is it important for both the health sector and the anti-poverty sectors to be here today and to be speaking to each other?
So thanks, Trish. You know, I've been working on this question and thinking about this for, I mean, as long as I've been doing medicine and truly beyond that. I mean, it's really the reason I went into medicine is to explore this idea. And maybe the best way to kind of to explain why I think this is such an essential sphere for the health world to get into is to start with a bit of a story. So I'm a family doctor. I spend most of my week actually in frontline family medicine, and I spend a part of every week actually working in homeless shelters. And I've worked in homeless service settings throughout my career. And there was a day that I remember a couple of years ago where I met for the first time a middle-aged man from the Middle East who came into my clinic in the shelter. And he'd been actually recently discharged from 3 months in an acute care hospital because he'd been involved in a car accident. He'd suffered a head injury along with other injuries. And he was someone who had no health insurance, no status in Canada, obviously no home because he was seeing me in the shelter, no source of income. And he'd been discharged to see me, the family doctor working in my little basement clinic in the homeless shelter, and I was supposed to provide ongoing care. And I'll tell you, on the surface, he didn't look too bad, although it became pretty evident through our conversation, even through a translator, that he was uncomfortable, right? In fact, he kept pointing to his head and saying, "It doesn't feel right. It just doesn't feel right." And I could tell that he had significant cognitive issues and memory concerns, which really seemed to be due to the head injury he'd suffered. And he, like me, couldn't understand why he wasn't in a long-term rehabilitation facility, being seen by a proper rehabilitation team every day. So, when I see someone like this, immediately my medical mind kicks into action, right? So, this is a complex medical case. The kind of issues list or problem list I want to lay out for someone like this, would go something like this, properly work up his neurological status, do a full cognitive assessment with him, bring together the proper multidisciplinary rehabilitation team for him, convene a family meeting to make sure he's properly supported through his process of recovery. And of course, for someone like him in that situation, none of that was possible, right? So my actual problem list went something like this. It was more like, try and figure out a steady source of income for him, try and find him some sort of appropriate supportive housing, work with him to deal with his immigration status, work with his lawyers to fight the insurance companies to get some money to help with his rehabilitation, and somewhere down at the bottom of the list, try and keep him medically stable enough to actually survive through this process, or at least not deteriorate medically. And unfortunately, this is the kind of story that I face on the front lines of what I do pretty much every day, right? I see this kind of situation, and it's very evident to me, and it's been evident to me for a long time, that the most important medical issues for people like this man and the others that I see really are their social health issues, right? Until we deal with their social health, it's very unlikely that their traditional physical and mental health is going to improve, right? And so this is where I start focusing on what we call the social determinants of health, which, is probably a term that many people on this call are familiar with, but I think it's important to recognize there's really kind of, I think, at least two layers of social determinants of health that we're talking about these days. Right, there's kind of the more traditional medical or material determinants of health, like income and housing and employment status and education. But we're also starting to talk about what I often call kind of the meta determinants of health, right? These are the big social forces that in many ways determine who is most impacted by those more traditional social determinants, right? These are things like racism and heterosexism and a history of colonialism and transphobia, right? These sort of big overarching social forces that are in many ways, they're built into our society. They're also in many ways built into us. So all this to say that there is a lot to kind of think about and to latch onto and to deal with from a health perspective when we're talking about addressing people's social issues. Two other points here. One of them is, I know this conversation is really about our role or where we can work together on poverty reduction specifically, and I've kind of blown up the idea of social determinants way beyond just income and poverty. I do think that poverty, and we can have a discussion about this, really is a kind of common landing ground for many social pressures, if not all social pressures in many cases. And again, we can kind of explore that as we move forward. The other piece that I want to say before I end this piece is just, we come from a very strong foundation of health evidence when we're talking about that link between social health and especially between poverty and people's health status. And I'm not going to spend a lot of time on that today because I think many people have seen this evidence, or if not, they kind of get it intuitively that there is a very strong link between people's social health status and their actual health outcomes. I can tell you that link has been shown through the health evidence in just about every health setting. So just about every chronic illness, acute illness, accidents, trauma. It's been shown in just about every geographic setting, right from the smallest locales within our country to a national level and, of course, to an international level. It's been shown with just about every population group, and of course shows that certain groups are at higher risk than others: children, seniors, Indigenous Canadians, people who are racialized, women, etc. But all this to say that I think the evidence is pretty much incontrovertible at this point, and I think we can start moving to the conversation about dealing with these issues as opposed from a health perspective, as opposed to just talking about whether or not there are issues that deserve to be on the table at all. So I'm going to sort of stop there, maybe turn it over to you, Trish, to talk a bit about where you think we might fit into anti-poverty work.
Yeah, and I think building on that, the fact of the evidence, and as you've laid it out so clearly, the depth of the evidence and the breadth that, you know, really in every context that you discussed, the evidence is incontrovertible. I think that really brings a strength to the poverty reduction work that we do. When I was thinking about this, I was thinking that there are maybe three advantages to, I think, really making visible and using that connection to health in poverty reduction work. One, I think, is that just that talking about poverty can be quite abstract. It's a fairly abstract term. We're talking about income levels, but I think it really brings it to life when you're talking about health impacts. When you're talking about the significantly higher rates of, cancer, heart disease, bronchitis, diabetes, not to mention mental health issues and suicide, depression. When you talk about it in those terms, it really brings home, I think, what we're talking about when we're talking about keeping people in poverty. And people get that. And when I use a story called the upstream story when I'm talking about poverty reduction, and it's really all about social determinants of health. And there's an aha moment when people are like, oh my gosh, what are we doing fishing all these people out of the river when we just need to go upstream and fix the bridge? And it really is an aha moment, and people are like, wow, this just seems like such a basic premise that we should be acting upon. Another piece, I think, is that there's a value in using health because we've already made that commitment. As Canadians, we've already said we're going to value healthcare, and we're going to pay for it together collectively, and we're going to take care of each other in that way. We haven't yet made that kind of commitment in terms of poverty reduction. We're moving that way, but we haven't quite made that kind of universal commitment. In fact, I would argue Canadian identity is almost built on our idea of universal healthcare. So I think taking that commitment and expanding it to all of the issues you mentioned in your two levels of social determinants of health is really powerful, because we've already got that value. So it's just expanding on that value. And then the third piece that I'd say is valuable is the fact that we can make the argument that poverty, impacts poor people, but inequality, which goes along with poverty, generally hand in hand often, especially in a country like Canada, inequality affects the health of all. So, if people are not convinced by the moral argument of taking care of each other, then the self-interest argument is that inequality actually affects us all, the health of us all. Living in an unequal society, it's stressful for us all, and that has an impact. So those are kind of the three that I broke out. There are many more, and we'll get into it later in the conversation. Yeah. Thanks, Gary.
Yeah, no, I couldn't agree more, Trish. I will also just add that there is good evidence to support the impact of increased income inequality in society on everyone in that society. That is a very powerful argument.
Right. Yeah. So I've heard you say, not my words, I've heard you say doctors can be a fairly conservative bunch. So how have you worked with them to address these hot button social issues like poverty and inequality?
Yeah, it's a very good question. And maybe the first question is why work with them to do this, right? If they are a fairly conservative bunch. And I guess that's really where this conversation is going, and the kind of reasons that you laid out, I think, are very powerful. And I will just reiterate that I think there is a huge benefit for the anti-poverty reduction world to bring on side the voice of health providers, with doctors kind of sitting somewhere up that pyramid, for better or for worse, as well as the resources of the health sector into this work. And so a lot of the work that I've been involved in has been really trying to figure out how we can shift the culture of the health world, and especially the medical world, to start seeing social issues like poverty as core health issues, right? And health issues that we feel that we truly have an imperative to address. And I've been involved. I mean, so I think the project of culture change is, of course, not a simple one. In fact, I won't claim to know how to do it, and I've sort of been stumbling and bumbling through this for the last 15 years or so. But I've really approached this from a multifaceted, multi-level type approach, and just kind of seeing what sticks, right? And luckily, a lot has stuck. And I'd say on the first level there, I sort of realized very early on that especially doctors and other health providers weren't likely just to jump into the front lines of anti-poverty struggles, right? They weren't going to get out there and pick up placards and and go protest in front of legislatures. So that we needed to kind of find ways to bring these issues into their environments and their settings, or my environment and my setting. So the first step in that was actually around developing a simple way to bring conversations about poverty, and actually conversations about intervening in poverty, right into the kind of frontline family medicine type interactions that we're involved in every day, right? And to that front, I developed something called a clinical tool on poverty. It's just a little brochure, basically. I mean, it's 3 pages, but it offers a simple 3-step approach to dealing with poverty as a health issue in the context of a typical 10 to 15-minute family medicine appointment. So, and these are, screening everyone for income, trying to incorporate the evidence we know links poverty with poor health into our clinical thinking, and then working to connect people with some of the highest yield income benefit programs that are available to them. So very simple. But for whatever reason, this tool really kind of touched a nerve within the medical sector, right? People are quite excited about this. Big health organizations picked this up. It was replicated right across the country for every province and territory. It was developed into educational sessions, everything from like 20-minute TED Talk all the way up to a 6-hour workshop that we now do on poverty, interventions for frontline clinicians. And it also started to mobilize like a real conversation, and a conversation that has continued to take on depth over the years about what our role is as health providers, frontline health providers in this work. It's also started to mobilize resources, which is part of what I was hoping for, right? So we now have been able to go beyond just that frontline interaction into developing team-based approaches to social issues like poverty. Like, for instance, in my team at St. Michael's Hospital, we now have 2 full-time income security health promoters on our team who only focus on improving income security for our patients. And they do this, with individual patients, but they also do it by educating our team, educating our community, and also by specifically having time dedicated to feeding what they're seeing on the front lines up into higher level policy advocacy. So, and that's sort of a feature of many of our programs. And we have other programs like a partnership with Legal Aid Ontario, where we have a full-time lawyer on staff, a literacy focused program, community engagement specialists, amongst others. So, and this has all sort of been paired with a really good research and evaluation program. So hopefully we will have the evidence to kind of push the spread of these types of programs in the health world in a very large way over the next few years. But there have been other ways that we've approached this, right? We've built it into curricula for trainee health providers and also for practicing health providers. And we've also worked to build a kind of network of leaders and champions really across the country to start talking about and truly about normalizing this idea of social interventions by frontline health providers. And I'd say the last part of this, which I think we'll get into a little bit more, has been, and this has been actually present throughout this work, has been pushing the involvement of health providers at the kind of social policy development and advocacy level. And really, I mean, this is my ultimate goal, right, is to start mobilizing this incredibly powerful sector to start pushing the envelope on social policy, right, and start changing the conversation in Canada, like what you pointed to, Trish, around social policy, to the point where we start seeing poverty reduction and action on social illness, essentially, as core to our identity as Canadians and as leaders within Canada. And I truly believe the health sector has a role to play there. So, Trish, I'm going to turn it back to you to kind of talk a little bit about your perspective on doctors, especially, and other health providers being involved in this work, and maybe challenge you to bring out some of your concerns about this.
Well, your tool came to BC, I forget how many years ago, but it was taken up by the Kootenay division of family practice. And they developed a local version for the Kootenays and then a BC-wide version. And then I think there have been many iterations since then, but it has gone across the country, and it has seemed to have a dramatic effect in starting the snowball rolling. And I love the simplicity of the tool. I love that number one is screen everyone. So it really takes away the stigma of judging by appearance, which a lot of people do with poor folks. And then you're really getting into the evidence and the poverty risks, and then the interventions. Excuse me, just getting over a cold. I love that it really brings an awareness, I think, to anyone who works with the tool to think about poverty as their patients are facing it. I did not know that you had actual staff that were able to do the work at the intervention level, because as far as I know, we don't have that in BC. What we have is a volunteer organization called Basics for Health, at least here in Vancouver. And so it's medical students who volunteer at some of the clinics locally and do that work, because that's a lot to ask, a family doctor themselves. Is a lot of seen as extra work. And so I'm glad that the conversations are happening to actually embed that. And you've got some resources to do that, to actually embed that in the medical model, in the frontline intervention. So I guess that would be my only concern, really, is that it's a lot to load onto doctors and other healthcare professionals at the front line. And so the resources are really needed. So the expansion of the healthcare conversation needs to happen so that we have the necessary resources in place, so that we just see this as the work of a primary care doctor. It's given that this is the work. Yeah.
Right.
Let's move on from, so that was sort of more direct intervention, but anti-poverty doesn't end in the office, of course. We've already talked about social policy changes. So how do we then pull the health and social worlds together to make those shifts in policy to end poverty?
I mean, it's a really good question. And I've been involved in actually quite a number of different approaches and different types of campaigns. Let me give an example of one of the more recent ones. I think it's actually been quite successful here in Ontario. And this has been a campaign around access to decent work, dealing with employment conditions, dealing with minimum wages, involved in this sort of Fight for 15 campaign that's been very prominent across the country, but certainly here in Ontario. And a number of years ago, a group of us health providers were actually asked to become involved in this campaign to bring out the health perspective on this issue, on access to decent employment. And we actually formed something called the Decent Work and Health Network. And what this did was actually bring together a truly interdisciplinary group of health providers, so not just physicians, but social workers, nurses, physiotherapists, occupational therapists, amongst others, and brought them into a direct working relationship with workers' advocates through something called the Workers' Action Centre here in Toronto, which has been a very powerful voice for workers' rights. And it's an organization that's truly run by people who've experienced precarious work. And so we really took guidance from the Workers' Action Centre in terms of where we could fit ourselves into this campaign. Initially, it started around just kind of gathering some of the background health-focused evidence and putting that forward through things like opinion pieces in newspapers, through media interviews. It moved into making deputations from a health provider perspective to government as they were thinking about their revisions of employment legislation. And it also involves health providers actually getting out on the streets. And generally, I mean, the only time I wear a white coat actually is when I go to protests around these kinds of things. Yeah. But, you know, getting groups of health providers in their white coats, you know, with signs identifying them as health providers in the midst of larger protests, generally trying to bring attention to this issue and really making it clear to the general public, the media, policymakers, that we see this as a core issue for the health world. And again, we've seen the kind of success and the extra hook that tends to provide in these types of campaigns. You know, and as many people on the call may know, we've had a good amount of success, right? I mean, there's been a very significant shift in the employment legislation in Ontario. There's been, you know, we were now at a $14 minimum wage, should be $15 by next year. And certainly not just due to health provider involvement, but I do think that we added a very important piece to the big advocacy work around this. So just to bring out a couple of, you know, a couple of the reasons that I think we have a powerful voice, and I think you alluded to some of these earlier, Trish. But first of all, that piece around being able to understand and interpret the evidence and bring that forward in a relatable way and from a kind of expert perspective. Second of all, bringing forward stories, right? I mean, we are immersed in people's lives, in people's stories on a daily basis in the work that we do. And I think have a really good and real foundation in those stories. You know, and third of all, again, being able to mobilize potentially resources from a sector that wouldn't necessarily put its resources towards this type of work, right? Both clinical resources, also research evaluation resources, and then just person resources, right? From the literally tens of thousands of health providers on the ground who, you know, quite honestly, with just a little nudge, get that these are health issues and are often willing to put their support towards this.
Yeah, I think that really speaks to what I would say on this as well, is that there is a legitimacy and a credibility that goes along with doctors and healthcare professionals speaking up around these issues. As I mentioned in the introduction, when I first met Gary, it was because we brought him into BC as the launch of our speaker series. And the whole idea behind the speaker series was to bring in influential people who would basically say the same thing as us, but are taken much more seriously, just to be honest, and reach audiences that we don't reach. So Gary presented did a workshop with healthcare professionals here through Vancouver Coastal Health. The one and only time that we have presented at the Union of BC Municipalities, so to our local governments, was with Gary. We don't get an audience with those people, and tons of media, CBC and lots of our local media outlets, business in Vancouver. Just having him as a doctor and that voice when he's saying the same thing as we are, but who's Marshall McLuhan, right, was a Canadian academic that said the medium is the message. And so I think that's what doctors do bring to it. He reached a much broader audience. And at the big public event that we had here, it was full, about 150 odd people, and it was new people came to the work because Gary Bloch was presenting. So yeah, there's a power in that. I just wonder, Gary, have you experienced any pushback on either the direct intervention side within the clinics or within this broader context of policy advocacy?
Yeah, I mean, there's a lot of pushback, not surprisingly. And it comes from a number of different angles. Certainly within the health world, there's an ongoing back and forth about whether or not this is a legitimate way to spend our time as health providers, whether or not we even have the time to do this type of work, whether we have the resources, whether this is truly a health issue worthy of us, right? Worthy of health, the health expertise to be put towards. And so, yeah, I mean, I engage in that conversation often and certainly hit walls on that. But I find that there are enough providers willing to engage in this that I'm not sure that matters so much at this point, and especially enough leaders within the health world willing to engage with this, that we're starting to shift again towards that kind of feeling of an imperative that I mentioned before. There's also very legitimate pushback from within the community of anti-poverty activists and advocates, right? And I hope some of the questions that come out today put this forward, right, and really challenge this. I mean, there are real problems with people with the kind of privilege that we tend to have especially as doctors. I mean, as health providers to some degree in general, but doctors, again, as a particular group, in taking up space, right, in this type of work, right, when really it should be people with lived experience of poverty, people who are most affected by these issues that have the most space to tell their stories and to frame these conversations. And I'm very cognizant of that. And I'm very cognizant of wanting to make sure that we are only doing what is most useful to people who are most affected by these issues, right? And I'm sure we have crossed lines on that. I don't think there's any simple answers to that. But there's a very real and thoughtful discussion to be had about how to draw or how to kind of keep us in our place, how to set boundaries around the involvement of health providers. And again, I would love to engage in that conversation more as we move forward with the discussion portion of today.
Yeah, we should probably move a little bit into the discussion. I know you did want to give us a little bit of an insight into some of the recent work. So you worked on the Ontario's Income Security Reform Working Group. We only have a couple of minutes before I want to jump into questions, but yeah, just tell us some highlights from that work.
Absolutely. So I'll take just 2 minutes to kind of mention this. And I will say to the people who are on the line here, please start sending in questions. I want to make sure we have time to engage in a back and forth. But I think it's worth bringing this out. I think it was quite unique, actually, that Ontario's Ministry of Community and Social Services, which is the ministry that kind of oversees our income security and social assistance systems, asked a physician to be part of this group that was tasked with laying out a 10-year path to income security reform for the province. And so I sat on one of 3 working groups that was focused on this. We kind of had a central working group, and then there were an urban Indigenous and a First Nations working group working in parallel to us. And I guess what I'll say is that I think the report that we produced, which came out a couple of months ago, it's at ontario.ca/income security, it should still be there. I think actually I think it's a very unique report. I think it is possibly the most progressive report to come out of government on income security in many, many, many years, actually. And it presents a vision and a realizable vision for the income security system that I think is actually deeply influenced and informed by having a health provider on that panel. In terms of, and it's not just from having the health provider, of course, but I can see the health voice woven through that report in the sense of, first of all, taking a very client-centered approach to people who are benefiting from the income security system, in terms of deeply understanding people's needs and the barriers people face in trying to get out of living in poverty, and in terms of developing kind of multifaceted plans for supporting people on that pathway out of poverty. And you can see that in the kind of vision there is for a transformed income social assistance system specifically, as well as for the broader income security system overall. So I would just encourage people to take a look at that report. In terms of the impact it will have, we'll see, right? I mean, the government of Ontario is supposed to release its poverty reduction plan based on our report over the next month or so. So we'll see what they actually take from it. But the response has been actually almost universally positive from both the anti-poverty activist world and the world of people truly living with lived experience of poverty. So I'll kind of leave it there, but I just think it's worth kind of highlighting and pointing to.
That's great, Gary. Thanks. So let us move into our Q&A part of the call. We had some questions submitted in advance, so we'll start there, but please do type in your questions as we go, or comments, and we'll do our best to get to all of them. But if we don't, we'll follow up afterwards. So firstly, many of our health troubles are related to our culture of total work. Overwork, work injuries, and work tension. Working less for employers, along with a guaranteed livable income, would greatly alleviate these issues. Can you speak to this issue, particularly concerning how we rethink the dominance of work identity in our economic, political, and cultural systems? Do you share concerns that a guaranteed livable income might take away from existing public health and social services?
I mean, it's kind of a multi-part question there. It's a very good question. I'm going to speak mostly to the last issue that was brought up there, because I think that's actually what I feel most comfortable speaking to. I mean, in terms of just the culture of work, yeah, I mean, I think this sort of speaks back actually to that issue around precarious work that I was talking about earlier, and the need to make sure that work environments are positive, serve to minimize stress and maximize satisfaction. I think a lot of that comes back to making sure that people are as empowered as possible within the workplace. Steps towards that certainly include protections for workers' rights. It includes an expansion, ideally, of union supports in the workplace, which, of course, we've seen the opposite happen over the last couple of decades. So there are really big social issues at play in this, and I think that it's really important to bring those forward. But then the questioner tied in this idea of kind of a guaranteed livable income, which, in some ways I think is actually a separate issue. I'm not 100% sure that just having a guaranteed income or a basic income would necessarily shift the culture of work, because there's no one design out there for this idea of a basic income at all. I mean, it is a very sort of diffuse and complex entity. I have hopes for, and I have significant concerns about the potential for basic incomes. I think if it is implemented, what to me would be the wrong way, it could be used to actually remove a lot of the kind of social supports that many Canadians rely on, and which I certainly rely on to help support my patients in my day-to-day work. And I think it would be a big mistake to think that just providing people with a base level of income could replace those other supports, right? And again, coming back to that work that I did on the Income Security Reform Working Group, we were very focused on a kind of multimodal approach to understanding what the factors are that keep people in poverty and at social disadvantage. And I think it truly does go far beyond just having access to adequate income. I'm not saying that can't be part of the solution. I don't think it can be the only solution. Curious about your thoughts, Trish.
Yeah, I would agree. I think when we're talking about guaranteed livable income or basic income, the devil's in the details, as they say. You know, you really need to figure out what that person or that group is really talking about, because it's being used by so many people in so many different ways, and across the political spectrum. So I think there are very real concerns that it's just another way to, move towards individualization and just putting us all out to market forces on everything, and we could lose so much. Ontario has its basic income pilot currently. We're just about to have something here in BC. We'll get an announcement in the budget, either a pilot or it might just move towards modeling of some kind, which avoids some of the ethical concerns around pilot programs. But regardless, we've put together a list of conditions that if a basic income should go ahead, it would have to meet all of these. And it's things like it shouldn't replace any of our other basic services: housing, health, education, childcare, all of those pieces. So it should be slotted into a poverty reduction plan, not to replace the whole thing. It shouldn't be used to subsidize low-wage employers, and that's a very real concern, I think. There's a responsibility for employers to pay well, to pay living wages, and to address all of the working conditions that you mentioned. So a lot of real concerns. But if it could be imagined as a radical restructuring of a very broken income assistance system, a welfare system here, with no stigma, with no bureaucratic hoops, medical hoops to jump through, then there's good pieces of it too. Okay, let's move on to another question. They're coming in fast here. So networks and coalitions addressing poverty reduction are always stronger in urban areas. In rural and remote communities, such as Northern Ontario, clients are often referred to healthcare specialists and paramedical professionals hundreds of kilometers away from home, and only sometimes eligible for reimbursements of travel costs. With added layers of vulnerability and with administrative head offices often being based in urban centers, for example, Timiskaming district, how will there be any true impact for rural and remote, differently abled, high needs people who may also be on social assistance or part of the working poor?
So another really good and complex question. I think maybe you need to do your next PhD on this one, Trish. So again, I mean, there's multiple levels here, right? And I think that on the one hand, the questioner is asking about access to health services, which is a very important issue from a rural and remote perspective, although maybe a little bit aside from what we're talking about here, which is really sort of thinking about the specific lens on poverty reduction within these types of settings. So I think I'm going to speak to that second issue more than the first, actually. You know, and I guess what I'll say here is we live in a very diverse country, right? And we live in, I mean, there's kind of diversity all around us, obviously, but then there's huge level diversity geographically, as we know. And there's a real difference in need, right? And I heard this over and over again in my work with the Income Security Reform Working Group, where we struggled with these questions around, you know, how to come up with solutions that apply across this massive province, right? And I think, you know, Ontario's issues are only reflected across the country in many ways. You know, I think there's a couple of pieces there. I think one of them is to make sure that the voices of people living in particular situations of vulnerability are heard. And that includes, you know, living in particular geographic areas, and includes people with specific needs or specific issues living in particular areas, right? So recognizing the kind of intersectionality of needs that arises in these situations. Second of all, making sure that there's appropriate resources devoted to those particular needs. And there has to be a recognition that that a higher level of resources are needed for people who are living in remote settings. You know, going to transportation, but also going to ensuring that services are able to reach into rural and remote communities. Also recognizing that some of those communities don't even have the level of infrastructure. I'm talking just basic infrastructure, right? Water, housing, that we may have in larger communities. And so even just starting right from those most basic levels of need and kind of building up from there. And I think we're starting to hear that conversation in terms of remote Indigenous communities in this country, you know, which is, of course, you know, where we hear the most devastating stories. You know, I think that need extends beyond as well into other remote areas in Canada as well.
Yeah, thank you, Gary. I think just to add to that, we have a consultation process happening here in BC around the development of a poverty reduction plan that the provincial government is hosting. And they're hosting a bunch of community meetings in some of our biggest centers around the province. But we really had to push them to also give out some targeted funding for those groups that wouldn't travel to those urban centers, both, you know, for differently abled, higher needs groups or groups facing much higher rates of poverty, but also around the geographical issues as well. You know, especially because they're holding the consultations during the winter, so people, you know, aren't going to be able to get to Prince George, you know, even if they are just an hour away. So I would encourage folks to look into that. If you've got some issues coming up in your rural or remote communities, there's an opportunity right now. Okay, we have a few questions specifically about the tool, the poverty intervention tool. And I'm going to give you all of them at once. We're going to group them all together if you can hold them in your head, Gary. So can you please confirm that the screening tool is the one found on the College of Family Physicians Canada? And have you experienced any pushback from provinces regarding the poverty screening tool? So maybe from the provincial government, any pushback there? Does the tool address addiction? And then last one on that. Have you had challenges asking patients about their First Nation status? At first glance, the question seems like it could be potentially off-putting in light of historical, current, inequitable treatment of Indigenous people in the healthcare system.
Yeah. Okay, so very simply, the tool, it is the one found in College of Family Physicians. The most up-to-date version is at a website called thewellhealth.ca. I think if you go /poverty, or there's a link to poverty, and that has the versions for the entire country. The College of Family Physicians site may have that as well. I haven't actually had pushback from provincial governments around this. I haven't had a huge uptake from provincial governments other than in Manitoba, where there's been really good support from the provincial government for organizing efforts around health and poverty. And they have something called the Get Your Benefits Project that I think has been a really good just intersectoral model of how to work with the health sector around the poverty issues. And they kind of started with a tool and then moved far beyond that. In terms of the addictions issue, I mean, simply the tool does not address addiction specifically. And I think I can kind of address that along with the question around First Nations to some degree. And I'll come to that other question in a moment as just in particular. But you have to remember the tool is not intended to be an endpoint. It's intended to be a conversation starter. It's intended to be, again, a first step into pushing the health world to have these conversations. I see it as really the kind of thin edge of a wedge, and that's really what it's served as, for me at least, and the kind of groups that I work with. So it is in no way meant to be seen as a comprehensive approach to social health. It was intentionally kept very simple and very focused and very simplified. And I think that kind of circles back to some degree to the questions around the challenge of asking about Indigenous status or First Nation status. The answer is yes. I think it is very simplistic to think that through one question you can enter that conversation with people. I think many people will not self-identify as Indigenous or won't even engage in that and truly won't even feel safe starting that conversation within a healthcare setting. This is not the tool that's going to start that, quite honestly. I did a fair bit of work with experts in Indigenous health and access to benefits to come up with that single question that was on the tool. And I'm in full recognition that if you took that as the only entryway into this conversation around access to benefits for people of Indigenous background, it would be very, very problematic. So it's a very good question, and my simple answer is yes, I recognize the limitations of that. But in the context of a tool that is really meant more as a conversation initiator in the health world, I hope it serves that purpose in that area. I mean, this is also why we have a 6-hour teaching workshop on addressing poverty interventions for those clinicians who really want to get into the issue.
Right. Yeah. Thanks, Gary. We are out of time for questions, though we have a great one that I'll just say it so that we've got it in our mind. I think this is an issue that a lot of us are facing, and I would love to follow up with our comments, which we will. So this is specifically to Peel. One of the challenges we're facing is social services and public health working in silos with almost no integration. What do you suggest as a first step so that we can work together to address poverty? So as I said, we can't answer that, but I really think that the silos issue is something that we're facing here with the provincial government developing the poverty reduction plan. And I think that the health angle actually lends itself to working across silos. So I see some strength there. Unfortunately, we can't get into more details. Thanks for your questions.
Sorry, and I will also just say, Trish, that the public health world has been very supportive of this, and in fact, has been at the forefront of conversations around bringing health and social issues and poverty specifically together. So there's real potential for a good conversation there.
Definitely, yeah. Thanks so much, Gary, and thanks, folks, for listening in and watching. We're at the end of our question period. Thanks for sharing, thanks for being with us, and for all your questions and comments, and we'll follow up on those that we didn't get to. I will pass it back to Alison for the final steps. Thanks, Gary.
Thank you, Trish.
Thanks so much, Trish and Gary, for being on the call today and for such a rich discussion. A couple closing announcements before we finish today. First, you're welcome to stay in touch with Vibrant Communities, Cities Reducing Poverty. Receive the latest thinking, news, tools, and resources from around the poverty reduction community by subscribing to VC's bi-monthly newsletter, Cities Connect. You can also visit the online learning community for poverty reduction practitioners at vibrantcanada.ca. If you enjoyed today's webinar, join us for the next Vibrant Communities webinar, Taking ABCD to Every Neighborhood. This webinar will be a discussion with Howard Lawrence, Karen Welk, and Chantil Shannon of Edmonton's Abundant Community Initiative. After having done the first webinar session on the ABCD principles, the second on ABCD lessons for implementation, this third webinar event will dive into the case study example of Edmonton, Alberta, where they're applying the ABCD approach to neighborhoods across the city. Learn about their successes, challenges, and key learning, and register using the link shown on the screen, which we will share with you through our follow-up email. If you're interested in a deeper dive professional development session, we have several upcoming in-person events. Move from a needs-based approach to an asset-based approach in your community development, neighborhood development, or community health work. This 3-day workshop will teach us core principles, dive into practice applications, and present local cases where they're having success. Meet world-renowned trainers Cormac Russell and John McKnight, as well as peers from across Canada and the US. This event's in Kitchener, Ontario, April 17th to 19th. Collective Impact 3.0. This event is for all collective impact facilitators or practitioners working at any level from beginner to advanced to collaboratively come together and help advance the theory and practice of collective impact based on your real-world experiences in doing community change work. This event will be held in Edmonton, Alberta, February 28th to March 2nd. Last event, the Evaluation Masterclass, is a 1-day workshop held in 4 major cities across Canada. It features community evaluation gurus Mark Kabaj and Michael Quinn Patton as the session facilitators and focuses on helping social innovators identify and stay true to their principles. This workshop will be essential to those designing, implementing, and assessing their organizations, strategies, or programs, as well as for evaluators crafting evaluation designs for social innovators working in a constantly changing environment. These dates are March 12th to 16th, and you can learn and register at the link that will also be shared with you in the follow-up email. So in the next few days, you'll receive this email, which will include links to the audio recording of today's call, as well as to the learning opportunities I mentioned. You can email Allison at tamarakcommunity.ca to provide feedback about today's webinar, or to Natasha at the email shown on the screen. We're always trying to improve on your experience. Thank you so much again for joining us, and I hope you all have a great day.